As you all know, every month we are conducting some webinars from the ASU. I'm happy that our council supports this type of webinars because sometimes if you are not able to attend physical conference, these webinars will help to update the knowledge quickly. Because the conferences we deal certain things in detail, we are covering this A to Z series this year, so that in this subject we will learn quickly in 2 hours all the related aspect of the disease. So today our topic is A to Z of carcinoma prostate. Primary program was designed by Dr. Deepak J. Kaddu. Can you share the screen and you are sharing? Yeah. Dr. Deepak is instrumental in this program. When I have asked him, he has taken all the responsibility. He discussed with the speakers. He has selected the topics. So I am thankful to him. Dr. Deepak is consultant urologist, robotic surgeon and uro-oncologist, Manipal Hospital, Whitfield, Bengaluru. He completed MCH urology from KEM Hospital, Mumbai. Fellowship in robotic urology, Verticuti Foundation, Astra Medicity Hospital, Kochi, Kerala. Performed more than 100 independent robotic surgeries. First to perform robotic kidney transplant and multiple advanced robotic procedures in Manipal, Whitfield. Part of India's first and world's second published level 3 IVC robotic thrombectomy. Performs robotic assisted kidney transplant and regis sparing robotic radical prostatectomy. Awarded International KSS Verticuti Best Video Prize 2025. National and State Best Video Awards at UCCon, CowCon, UACon. Published landmark robotic kidney transplant and IVC thrombectomy.
Thank you, sir. Thank you for kind introduction.
And good to know that you have such credentials. I didn't know that. I am very happy. The second important consultant who is going to help us today is a knowledge person from PGI. That is our contemporary and little junior, Professor Ravi Mohan S. Mauduru. He has recently involved in the uro-oncology after the subdivision and contributing lot of work, and he has lot of experience at PGI. His current designation is Professor, Department of Urology, affiliations PGIMER Chandigarh. He was the Chakrabarti Fellow 2015, Hargovind Singh Memorial Travel Fellowship 2021, JUA Fellow 2012, ESUP Fellow 2014, Past Secretary Uro-Oncology USI, Secretary Robotic Urology Forum, published 176 journals, great, editor of Urology Cancer Clinics of India, and also he has become council member recently from the North Zone. With this introduction, without wasting time, first speaker also I will introduce. The first speaker topic is PSA interpretation and diagnostic pitfalls. So, Dr. Gopalakrishnan is the speaker, who is assistant professor and in charge of uro-oncology division, Amala Institute of Medical Sciences, Thrissur. Fellowship in uro-oncosurgery from Tata Medical Center, MS General Surgery from Government TD Medical College, MCH Genitourinary Surgery from Government Medical College. He was instrumental in starting a dedicated uro-oncology unit first time in Thrissur. Member USI, ASU, UAK and ASI. I'm very happy to invite him. Over to you, Dr. Midhun. Can you stop the sharing? Yeah. Please stick to the time. 8 minutes is short time, but majority of the presentations nowadays are short time only because we have to accommodate more. You should be more conclusion-oriented talks than detailed discussions. Naturally, you people are experienced. Please do that. Those who are listening to our should feel that something updated knowledge I have in today. That's a feeling. All the 90 people have joined for a webinar online. Nowadays, 90 people is too big. Thank you.
Thank you, sir.
Good evening, sir.
Yeah, share the screen. Midhun, you are sharing now?
Yes, I am here, sir. Can you please share the screen?
Yeah. The presentation is with us. Rajendra, just check. Midhun, presentation is with us.
Yes, we have uploaded just now.
Because I have not
Yes, we have uploaded.
Okay, please unmute except the speaker. Request all the other co-speakers also. Lot of voice is coming. We can unmute, but it is an additional burden for us. Yeah. Is the screen visible, Midhun?
Yes, sir.
Yeah, go ahead. Take.
So good evening. Today my topic is PSA interpretation and its pitfalls.
Can I take control?
Full screen.
You can take
How
the
to change
control.
the slide, sir?
Yeah,
Yeah,
enlarge the
you can
slide.
make the
Zoom
full
meeting
screen.
ఉంది తీసేయ్ ఏందో ఎక్కడే జరుగుతుంది
Full year.
Uh,
గోరి ఫోన్ చేశాడు జూమ్ మీటింగ్ లో
can you please give me the control?
It's big, Chino. Cannot crush it.
Can we take the control from there?
Yes, sir. Already control.
Do you have the control or not?
No, I don't have any control now. One second, I have to.
So
Can you see my presentation now, sir?
yeah. Yes.
Yeah,
Yeah.
we can
So we'll.
see.
Okay. Good evening. Today my topic is PSA interpretation and its pitfalls. So I will discuss it under for these headings. What is PSA? We all know it is prostate specific antigen. It is also known as human kallikrein peptidase 3 (HK3). It is released from the prostatic luminal epithelium and are found in seminal fluid and serum. Its function is to liquefy semen, and through its action on a gel form proteins, seminogeline and fibronectin bound form, as well as in free form, in the age, race, and prostatic volume. Proper, we need to know how PSA is being processing. We are actually estimating to diagnose a pre-pro PSA. It is actually a PSA result in inactive pro enzyme termed pro PSA and cleavage. Now, this is the age-adjusted standards. So, on the other side, we have given the upper limit between 40 to 49, 2.5, 60 to 69 is 4.5. Upper limit for Indian patient when compared to the Western less than 40, the upper limit according to their study in Indian scenario is 1. And 41 to 50 to 70, it is actually 5.8. And 71 to 8, and if it is age is more than 80, it is 11 bit low when compared to the Western population. EU guidelines say if it is going to change the management disease, then we need to do. They have divided to 3. It is 40 to 40 patients with a family history and black ancestry. A man without specific risk factors comes to average risk in individuals. Those patients we need to start. Now 50 to 70 screening, more than 75 according to AUA recommended screening strategy. No single cutoffs and over treatment, and need to avoid an unwanted prostate biopsy. Except all these things in our daily practice, we divide it to basically 3: less than 10, more than 10. So less than 4, MRI and prostate biopsy. So what is
4 minutes.
if the PSA is so what is this free PSA? Proteolytic processing more frequently. This prostate cancer. The percentage of free practice like our total to 25 and lower is less than 10%. Whereas lower percentage of free PSA, it is actually 0.5 or greater was proposed as an indication for prostate biopsy in our PSA velocity greater than 0.5 as an indication for prostate biopsy in the grade only done in indices this PCA3. That is prostate cancer antigen aspect. Prostate health index is it's a formalized risk. Low risk is below 27, moderate. Now 4K score for formula is proprietary and they have not disclosed it. Again divided to low risk, higher risk, low risk, and the cost is 28,000, around 28,000. PCA3 score in urine, it is after doing these urine PCA3 mRNA and urine PSA mRNA, it is less than 20 low, 20 to 50 intermediate, so high score is more than 50. So
1
and
minute.
another indication for PHI, 4K and PCA3 is to take a call and report. Now, what are the false positives in serum PSA elevation? BPH, prostatitis, prostatic manipulation, endoscopy, then ejaculation. They say PS cycling. It can even cause raise some PSA values. Use of 5-alpha reductase inhibitors, some NSAIDs and certain diuretics, negative value of serum PSA, and it is said that around % reduction in the apparent value of serum PSA. Strategies to mitigate pitfalls: repeat testing, biomarkers like PHA, 4K score, and PCA3. Final takeaways, take home message: PSA is a very, but we need to interpret it cautiously, knowing the false positives and false negative factors. There are a lot of other biomarkers as well in our armamentarium, but most commonly used are free PSA and serum PSA density in a case of 4 to 10 gray zone PSA. With the advent of multiparametric MRI and its cost is becoming more affordable, the routine practice is more towards multiparametric MRI in gray zone compared to all these indices and etc.
Excellent. You finished in time.
Hi,
Can
sir.
I ask
So
a
very
question?
nice talk. In a day-to-day practice, to remember, you don't have to remember the various cut that you should do a PSA if there's a family history of CA first degree relatives, or rest all patients beyond 55. So lot of practice with PSA being 40 years and getting unnecessary education. To remember is don't do this or AUR and things like that. First thing you do is to do a PSA, and then these are two things. Otherwise, largely is standard unless we have our own. Thank you.
Ravi Mohan, one small question is having PSA of 3 and is not suspective of carcinoma prostate. What is the PSA level that we should consider since then? Common question, but sometimes we start after 3 months, it should be halved. That is the theory.
Correct.
Is it the same thing followed after that? It should be half of the whatever the
Yes.
value you should multiply into 2 whenever you
Absolutely.
multiply.
Absolutely. In a day-to-day practice, once you've started dutasteride, PSA would fall, and the next interpretation of PSA at 3 months should be double of what the PSA is
Double of
at that
what?
time. So it's very clear.
Very clear. Deepak, you wanted to say a few
So
words?
one question, like he told about all markers and all those, we in the routine practice, we generally don't do. So what we commonly encounter as an high PSA value when the prostate cancer is not existing is mostly the acute urinary retention, prostatitis, and you give the antibiotic, you relieve the acute urinary retention. So those things should be we should be talking, because very rarely we do these markers, which are very costly to do, and mostly we follow repeat PSA.
Deepak, one more question. More than 75 years, if any patient comes with other problems known to you, is the packages include PSA or should we do? For example, my own relative is 75 years, he never underwent PSA. PSA in your hospital, corporate hospitals, what is the protocol? 75 years.
Sir, here in corporate, for all the patients, male patients above 40, you get even young patients with the serum PSA. But if the patient comes from a lower urinary tract symptom, then only
Ravi Mohan, controversy of PSA misutilization, a brief comment, where old people or younger people? What is the current PSA used? Maybe good or bad, we don't know.
So the first answer, sir, both extremes. So if you do PSA in a very early age, is also you do PSA at a very beyond 75 is also wrong. So to answer that comment about you asked Deepak that a patient is more than 75 years, Midhun also highlighted as per EU guideline, which is very correct, that when you do a PSA, if the utility of PSA, which is like biopsy and follow up into surgery or radiotherapy or something, if those things are not going to, this is not going to help. So there's no point in doing such situation. That is the key. India, I think, since we don't have our own data, it is always wise or it is good. We have some data of our own, like Sanjay, one paper that was from a private setup. Similarly, a government setup. So you'll have all the type of patients where we'll know our own cutoff, because there's paper from SGPJ which says in Indian patient PSA cutoff is higher. Whereas paper by Sanjay Adla, they showed that PSA cutoffs of our Indian patient is lower. So these are very two different spectrums. Unless we have data, we cannot.
Okay, so we'll move on. Deepak, don't mind. I will be some initiative for this discussion, because discussion creates some amount of interest.
So, but we do generally opportunities.
Right. So Dr. Vishnu Prasad is a prostate and pyrids, a practical guide, urologist and uro-oncologist, Manipal Hospitals, MBBS from Kasturba Medical College, Mangalore, NCH from Vardhaman Mahavar Medical College and Safdarjung Hospital, New Delhi, fellowship in uro-oncology and robotics, AMS Kochi, specialized in robotic and minimally invasive urological cancer surgery, expertise in prostate, kidney, bladder, testicular cancers. Vishnu.
Good evening, everybody. Is my screen okay? Yeah. So thank you, Chandran sir and Unity. So I'll be talking about MRI prostate and the pyrite scoring. So because quickly go into the topic, anatomic component that includes the T1 and the functional component, that is the contrast enhanced MRI. There was MR spectroscopy, which is currently known as 2.1 version, and I did there 1.5 Tesla with a endorectal coil. Just the MR, the prostate looks in the MR to 80% of the prostate cancers, high intensity, that is a hyper intensity in CT scan, and seen best in the coronal zones, which is a low to intermediate intensity area in the center part. This has only about 1 to 5% of the tumors. The zone, as you know, lies in the center part, that they have they can harbor up to 20 and a prostate cancer in the transition. There are a bit of limitations for finding something called as the anterior fibromusculoma, which lies in the anterior part, usually that part as well. Neurovascular bundles. So these occur as basically a low intensity various fascias here at the fibroations. Things we've seen in the axial cuts, in the sagittal cuts, these appear as very high intensity. And here you can see in the T2 versions, you can see a very high. To what I mentioned about the anatomical T1 is basically directly post-hemorrhage. So any patient who has undergone an MRI quite recently can just. That is why it is suggested between the biopsy and the MRI. And anatomical images where you look at Kurnool cuts and the sagittal cuts. On the axial cuts, this is a T2 where the peripheral zone appears as a bright intense lesions. You can see the urethra in the center. Look at the surrounding structure. This is the levator, the neurovascular bundles, as well as this is another imaging where there is a high background of hyperintense. So this is based in the left peripheral zone. This is actually imaging. So this comes to the functional part of water in a magnetic field. The bit is a more cellular tissue is shown as a high signal on the diffusion weight, called as a B value. So B value is a threshold for restriction. When the B value glands becomes very bright, because prostate itself is a very highly cellular or hyperintense or dark or spot seen on the B value of 1000 is indicative of cancer. The opposite of the ADC map will be a exact inverse. White spot on the B value will present as a dark spot on the ADC. So just remember, spot on the diffusion weighted imaging, dark is highly suggestive of a prostate cancer. The dynamic contrast is basically just a contrast with a gadolinium-based agent, neoangiogenesis. So there is early recovery of the contrast. If there is a type 3 curve, that is early enhancement with highly indicative of a prostate cancer. Now, DC basically is like an adjunct. So whenever the cases diffusion weighted imaging is not clear, this helps. There's a lot of gas in the rectum. The diffusion weighted is not very clear. We can't see anything here. See a lesion on the T2 weighted images, whereas it is enhancing on the contrast. So this is very indicative of prostate cancer. It really helps in patients where the diffusion weighted is not very clear or an intermediate type of cancers. So we have talked about the anatomical and the functional. How do they actually report these PIRAD scoring? Okay, the latest version is still 2.1, I believe, from 2019. This is a very, very important, most important thing to look at in peripheral zone lesion will be a diffusion weighted image. One PIRAD score of 2 becomes 2. The type 3 or a 3 score of there, the enhancement becomes very important. If it is enhancing, it becomes a 4. If it is not enhancing, it becomes a 3. Okay, diffusion weighted secondary will be a contrast. Here, the T2 lesions are not very important. But if you look at transitional zone areas, it is the T2 lesions that are that will decide whether it will go to a 1, 2, or 3. Here also the secondary important one, diffusion weighted imaging. So one takeaway, transitional zone T2. You can also see at lymph node, very important to look at lymph node meds. You can even, or an MRI is more sensitive than a bone scan and even certain PET scans. We all know about these PIRAD scoring ranging from 1 to 5. 1 is a very low risk of cancer and 5 is a very high. Tell these patients, suppose we find a PIRADS 2 or a PIRADS 3, how do you tell the risk of cancer? So there are various studies all the way from 2016 to 17. A PIRADS 2 has approximately 5% chance of cancer. These are just average numbers, 15, 40 and 65. If you can remember these values, you can always counsel the patients that anything beyond 3, usually the biopsy a prostate biopsy. There's new talks about get away with the dynamic. I've looked at it. That is biparametric means it. That is also good enough, but not a biparametric MRI. Now, why are we talking about all this? How does it actually help in our practice? So MRI is very important. As we talked about the previous speaker also, the PSA is not a very good test. PSA between 4 to 10, we have to do an MRI. An MRI is indicated before any biopsy. So if we keep a threshold of PIRADS 3, we can avoid 30% of all the biopsy procedures, whereas we will miss around 11%. So these are the numbers that we should be quoting in examinations and also when we talk to patients as well. When we do a MRI targeted biopsy, so do we do MRI targeted biopsy along with a systemic biopsy? It increases the rate of ISUP more than 2 and ISUP more than 3 cancers up to 20 and 30% respectively. Whereas if we go to a repeat biopsy setting, it actually becomes 40% and 50% respectively. So MRs in finding out the seminal vesicle in guidelines say adhere to the PIRAD guidelines for MRI acquisition. Do MRI before all prostate biopsies. Be whatever the indication, it's better to do an MRI. Obviously, if the MRI is positive, combine targeted with the perilesional. So I think this is something which is newly introduced. Maybe the last few years it is introduced. Now we're not talking at systematic biopsies. You take multiple cores around that or that particular lobe. Studies have shown that the opposite lobe may not really help. So this is some changing in the AU guidelines. If they have mentioned if the risk is very low, 0.1, negative DRE, and no family history, you can still omit a biopsy, but make sure that you follow up with a PSA. Other things includes, obviously, I think we'll be talking about cognitive and in-bore biopsies, post-radiation. So patient undergone radiation to look for recurrence, MRI really helps. It's also indicated in the follow-up of active surveillance. I just have one last thing, Deepak. So just an example. So this is the T2E1 hypointense lesion on the very indicative of prostate cancer. The size is around 1.2 centimeters. So this comes to be always confirm T2 with the sagittal as well as the coronal images. They should think. And I told you for a peripheral zone, what is the primary sequence? It's going to be diffusion weighted imaging. In the diffusion weighted imaging, you can see it appears as a bright spot. On the ADC appears as a dark spot. Okay. There are various categories to calculate diffusion weighted. That becomes too complex for this talk. But basically, it's going to be a diffusion 4 category. Okay. Now the enhancement also is showing on the DCE. It shows a positive DCE. So a classification, it becomes a type 4 diffusion weighted imaging. It becomes a PIRADS 4 lesion. So that's how radiologist calculates. Okay, it's always best to cross-check with the imaging and see if they calculated it properly. Okay. Thank you.
So to summarize short, the prostatic cancer lesions will be hypointense on WI, it will be hyperintense and ADC, right?
Correct.
So and peripheral zone, it is mostly you look for DWI and the T2 weighted images, you look for the trans.
Correct.
So the one popular cause suspecting a metastatic prostate cancer with very high PSA, you will still stick to going for go for a PSMA PET.
No, I just mentioned that for metastatic, we don't have to go for an MRI. We can either even go for a biopsy scan as well.
But doing biopsy without MRI, as the PSA is high, you're expecting it is.
Yeah, because I don't think we'll be treating it locally, really make any difference.
In institutions, even Deepak, do you people see, we are well versed with how to see carcinoma. I can identify tumor thrombus that meticulously. What I do is finding, ultrasound finding, radiologist, and I will ensure that during my this thing. What is practiced in PJ, things will be changing. Now we are doing MRI very well. Is it that much of the onco-focused urologists can read any minor dot and interpret the PSA Gleason score properly? That's what about you people?
So, first of all, Vishnu, very nice talk you covered. So one thing which is going right, which we cannot because next it will come in guideline for sure. Already there is a prime recently. The bioparametric MRI, the advantage is equivalent to the without contrast enhancement. It can still give same information, and it is very less time consuming. So people are trying to move away with as an MRI as a screening tool. So biparametric is going to stay there because it's only 10 to 15 minutes for a biparametric, whereas with DC, you have to have a very different protocol and, the technician has to be trained. Now, coming back to Chandramohan sir's question, as a urologist, it is almost mandatory. I think we ensure that our residents in training, they go to the radiologist, sit there and read the MRI themselves. So as a practicing uro-oncology, if somebody is clearly interested in uro-oncology, it is very, very essential because ultimately to know the MRI, to be able to read the MRI. And if once you get into the knack of reading it, then I think between you and radiologist there will be 80-90% concordance there. So both will be equally wrong when the lesions and both will be equally right when they pick up the lesion. So to ensure that we as a, because when you do biopsies on the urologist, not on radiologist, that okay, we did a targeted we targeted a biopsy. So that's the only.
Deepak, one question asked for acute urinary retention. When should we repeat the PSA? Previous talk question for the general practitioners.
So a very important practical question, sir. Like first, we should put the catheter and start him on the alpha. Repeat after 15 to 30 days cause any issue.
Scientific, Deepak,
More
is that when
but-
when the patient is retention, the typical half-life days. So you wait for 4 half-lives. That is repeating at 15 days. Again, 4 to 6 weeks is a good time. Secondly, that dutasteride. So you said you start alpha, your values are going to be haywire. So again, alpha blocker based on whatever you want to give.
Artificial intelligence is also coming in the 10 and ask AI, give me the, it will show the marking and so that we can see better. Can it
Vishnu.
happen?
Vishnu can take
yeah,
that.
yeah. So I have it a few studies. In fact, I have another talk on AI in urology, which intelligence, which can identify the lesion as much clearer picture. So there'll be units or a common scoring system compared to multiple readers. So that is definitely coming up. I think next few years, it's all going to be about artificial intelligence.
Okay. The talk that is Deepak Kaddu only is prostate biopsy. Trust. Over to you, Deepak.
Yes.
Meanwhile, Ravi, please.
Prostate biopsy, transrectal versus
Sure.
transferineal, how, when, and what to do. I'm not keeping anything as a superior because both has its pitfalls and advantages. So indications of prostate biopsy, I'm not going into detail. Generally, we do with a high serum PSA or MRI showing positive, like PARADS 4 or 5, or a hard nodule. So schema of my practice and image guidance. Then why to do before the biopsy. Then what are the types of course like systematic biopsy, targeted biopsy. Then how we do a transperineal biopsy. Then the next is how is the who are following it. And then the comment of the guidelines and how they do the prostate cancer detection, and advantages and disadvantages of both the biopsies and take-home message. By and large, transrectal and transperineal, and most of the Indian centers of urology, they follow transrectal, but slowly transperineal is up guidance. So first, people urologists used to do with the blind, finger guided, most commonly used with the mostly a biopsy. Then has come the TRUSS MRI fusion biopsy, which is an upcoming topic, and then the MRI guided in-bore technique, which is less commonly used, maybe in the centers like PGI. So brief in transrectal biopsy, most of the people or most of the urologists know how it is done. So left lateral decubed disposition, cleansing with the betadine, the anal rectal axis is mandatory. Use a biplanar protein gog, and we generally take 12 plus separate formalin bottle. So now 2017-18, there are 3 trials which has changed this prostate biopsy scenario. Trial and MRI first trial. So what promised trial? It was done by Hashim MRI before proceeding for any prostate biopsy. So coming to the precision trial, that is Kashi Vishwanathan. So it showed if you do the MRI before the prostate biopsy, the chances of detection of clinically significant cancer is more, and non-significant cancer like grade group 1 is less. Rationale of MRI doing so, you will reduce the biopsy by 51% unnecessary biopsies. You will increase the chance of high-risk prostate cancer detection 17.7% and decrease the low-risk prostate cancer by 89.4%. So we should take. So so most commonly followed is a targeted, that is around 12 plus 6 to 8 course, that is around course. Or some centers follow targeted plus perilesional. So each lesion, around that lesion, they will take 3, which is again recommended guides. In most of the hospitals, when we schematic code, that time the MRI, but in the later course of our another trial, which is MRI first trial, which neither the systematic biopsy are complementary. So systematic biopsy plus biopsy should be done to increase the yield of prostate cancer detection. There is another study suggests the targeted is the lesion detection is equivalent targeted biopsy plus perilesional. So what is this perilesional? Is 10 mm penumbra around the lesion site. You target all that area and take 3 to 4 or 4 to 5 biopsy course. So now going to the transperineal biopsy, which is less commonly touched by the young urologist, and it is in uro-oncology setup. So it's always done under anesthesia and software based. So freehand, they use a Prestin, which is a common access point, 2 access points at the on both the side. Then the grid system, the grid and the stepper will be required, which is costing. You require a machine, you require a software, range from 1.5 to 3 CR, which is an invest, especially in a small transperineal. When we go based or a freehand base. So in the grid base, you could the pubic bone comes in between, especially in case of a large prostatic biopsy you are going to do. Then when you are going for a freehand system, that is those bony obstacles won't be coming. So what are the accessories required? So for a grid based, you could see there is a probe, then there is a grid system, there is a stepper. And in the this freehand system, the precision point access, which is quite common, so that accessory will be required. It stabilizes the needle and it makes aligned with the probe. So transperineal biopsy, and shortly going in, I'm not because of short of time. So this is the fusion, this is the patient position, extreme lithotomy. And then after cleansing the area, you go for a local around that area, then do the grid setting. Then you go for a peg block. So in the periapical triangle, you inject the lignocaine plus bupivacaine anesthesia mixed with saline, and then you wait for some time, and then you go for the fusion biopsy works. The MRI image acquired, and then the ultrasound images are acquired in real time by the transrectal probe, and those are fused in there. So I'm just discussing in short with the softwares. And those after biopsy. So MRI Trust Fusion softwares, we have a BK Fusion, we have Artemis, and we have Coelis. So how like most commonly going through some of the major centers who do transperineal biopsy. So Rajiv Gandhi Cancer Center in Delhi, they using Artemis. Max Hospital, they are using Artemis. In Mumbai, Kokilaben, they use BK Medical. HN Reliance use Artemis. In Chennai, Apollo and Curie, they both have BK Medical system. In Bengaluru, there are varieties. So Fujifilm is there, Artemis is there, Euronav is there, and Sri Shankara. Fortis is there. Fortis have a BK Medical, but Sri Shankara and transrectal biopsies with this, not the transperineal. This trial tells future trial, the software fusion, whether you do with the cognitive. So the biopsy detection, the cancer detection rate with the biopsy are almost similar. The fusion is important. So when coming to the complication, transrectal versus transperineal, you could see the infection and sepsis chances are going through the rectal mucosa, and your infections are more common in the transperineal, reduced and almost make to prophylaxis and pre-procedure. So when coming to the EU guideline, the transperineal, so this of 12 studies which showed the rate is quite high in transrectal, so the transperineal biopsy has been as a first choice by the EU guidelines. But in the prevent trial, infection rate is same when the antibiotic profile is given before the transrectal biopsy. The drawback, which is for the perfect trial, which there are some sayings like if the lesion is anterior, go for transperineal, lesion is posterior, go for transrectal biopsy. So perfect trial tells the same, overall is the same, but when it comes to the whatever the site of lesion, anterior detection is almost the same with the transperineal and transrectal route. So what are the advantages of transrectal biopsy? It is less cost because there is no costly investment and software record. It can be easily target the huge prostate. It's better for a posterior lesion, has a less learning curve. This can be mitigated with the antibiotic profile. So what are the advantages of transperineal biopsy? In the 2 to 4 days, patient, we can post a radical prostatectomy if the cancer biopsy is positive for the cancer. Highly prone for UTI like diabetes or is better to go for a transperineal, which has then predominantly anterior is transperineal, and sometimes you can just insert a probe but can't do a biopsy is better. Most importantly, biopsy is marketed by the urologist and it gives an upper hand. It keeps the hand of urologist who is responsible for positive or negative biopsy and the outcome of the patient. Advantages because in India, most of the urologists are doing transperineal biopsy, not the radiologist. So in the transperineal biopsy having the scientific advantage, the most common fact is the cost. Because one transperineal biopsy, which is under anesthesia in a private setup, can cost from 70,000 to 1,20,000, 1 lakh care procedure and or a 24 hours admission. The prostate cancer detection is same as per the perfect trials. Change the chances of cancer. Infection chances which are higher in the transrectal can prophylaxis as per the prevent trial. Quite convenient to do on OPD basis. Transrectal biopsy.
Cognitively fuse whatever you see on MRI and target the lesion, because the entire idea of this biopsy is to have a right yield. You don't want to miss a cancer. Right yield. You don't want to miss a cancer if it is there. That's it, sir.
Okay.
So
Thank
in
you.
our center, sir, we generally practice transrectal, so that might be the reason. But whosoever center I called for the transferrin biopsy, most of them are doing under sedation or general anesthesia. So
But
none of
general
them are
anesthesia
doing
is
under
too
local
much.
anesthesia. So
But
none of
general
them are doing
anesthesia is
under
too
local
much.
anesthesia.
I also
No,
think
no.
general anesthesia-
We in the last uro-oncos, we did had a work biopsies, and all three patients were done under local anesthesia. And both were done, and it was under
But
local
Ravi Mohan,
anesthesia.
which mission?
No, yeah, we are using big. We
Any
are
other
not yet
mission
doing.
other than BK which is cost
Doing.
effective quickly?
Sir,
Deepak,
Euronav the Sri Shan.
cost effective quickly.
Sir,
Deepak,
Euronav the Sri Shan 1.5, like maximum 1.5.
more than one is to
1 CR only, sir. 1 to 1.2
yeah,
CR.
1 to 1.2 CR. Anyway, thank you. We'll go to the next speaker. Can you project the next speaker? Sepuri
Questions,
Bala,
about the
Dr. Sepuri Bala Ravi Teja. Can I Ravi Teja a little
Yes, sir.
clear till we say
Yes, sir. Sorry.
consultant urologist, andrologist, and uro-oncology center, Kurnool. Performed first laparoscopic